Welcome to our weekly gathering where we make it okay to talk about all things menopause. We cover the clinician and medical side, the lifestyle, nutrition, and exercise, and also the emotional and real side to all of this. I'm Melanie Olson, Community Director here at Gennev. And side note, I'm going through perimenopause, so I totally get it. Today, we are going to deep dive into a topic that I'm very excited about. The month of October is Breast Cancer Awareness Month. It also happens to be Menopause Awareness Month, too. Side note, at Gennev, it's menopause awareness every single day. But today, we have Dr. Rebecca Dunsmoor-Su, Gennev's Chief Medical Officer, and Dr. Lisa Savage, Gennev's medical director, both physicians here to talk with us today about the intersections of menopause relief and breast cancer. Dr. Lisa Savage is a board-certified obstetrician gynecologist and has spent 3 decades taking care of women. She received her medical degree from Baylor College of Medicine and did her residency training at Emory University. She was in private practice in Austin, Texas for 25 years before taking a sabbatical, during which time she started working with Gennev. We're so grateful you're here with us. She's a fellow of the American Congress of OBGYN and certified by the American Board of OBGYNs. She lives in Austin, Texas with her husband and rescue dog and has a young adult daughter and a new son-in-law. Dr. Rebecca Dunsmoor-Su's experience in women's health began in residency training in obstetrics and gynecology at the University of Pennsylvania. Her experience as an OBGYN clinician, educator, and researcher at the University of Washington and previously as director of menopause at the Swedish Women's Clinic has fueled her pursuit and passion and expertise around women's health. She is the chief medical officer here at Gennev, lives in Seattle with her family and husband, and loves to travel. Both Dr. Savage and Dr. Dunsmoor-Su have navigated breast cancer personally, and as menopause expert MDs, also treat people going through menopause. First off, what an incredible intersection of knowledge you both bring to this conversation. Thank you so very much for joining us. I'll let you share your individual breast cancer story to start us off. Dr. Savage, do you mind starting?
Happy to. Hi, everybody, and welcome. So glad to be here. I was diagnosed with an early stage breast cancer in my late 50s. I had been on hormone replacement therapy of one form or another most of my life. I want to point out that that did not cause my breast cancer. I underwent conservative surgery, subsequently had radiation therapy, and I am on ongoing endocrine therapy. I want to tell just a little side story around my diagnosis because when the doctor called with my biopsy results, I kind of knew what it was already. I did shed a few tears after we hung up, but I want to tell you that my tears were not so much about the diagnosis, which was kind of what I expected given my physical exam. My tears were because I knew they were going to take away my HRT, which they did, and I understood. But that just kind of puts it in perspective as to, how I put those two together and what I was most sorry about in that moment.
Oh yeah, that's one of the hardships, isn't it, around this conversation is that lack of that. Thank you so much for
I was
sharing
going to
that.
be one of those ladies that said, "You're going to take it out of my cold, dead hands."
Yeah, it helps a lot of women provide a lot of relief, doesn't it? Thank you so much for sharing your story. Dr. Dunsmoor-Su?
Yes, I'm happy to share. So my story is a little different from Lisa's. I was diagnosed actually premenopausally, and I had cancer in both my breasts. So I did not have conservative surgery. I had very significant surgery. I had both of my breasts removed, a double mastectomy. Luckily, did not have to have radiation or chemotherapy once the pathology came back. And but I also had my ovaries removed due to some genetic cancer risk. So I was put into a sudden menopause at the age of 48. And since then, I've been on endocrine therapy. So I use tamoxifen. And so I've been navigating menopause since then.
Excellent. That was a massive undertaking to go
It
through.
was
And
it was a shock to the system.
yeah, no doubt about it. And what are some of the things that you learned through that? It sounds like you got diagnosed through, was it just a standard mammogram?
So it was not a standard mammogram. It was actually an MRI screening after my standard mammogram, but
Yeah.
it was screening. So one of the things I always emphasize with my patients is whatever the recommended screening is, you need to get that screening because I would not have known the cancer was there. I was having enhanced screening because I have genetic risk. And that's why the enhanced screening was done.
Yeah. And Dr. Savage, how was yours found out? Was it through a screening like that or through another? I think you maybe shared that already.
Well, I alluded to my physical exam, so I have a different story, and I want to put a plug in for women who have really, really dense breasts because my screening mammograms, which I never missed, were all normal. But I eventually developed a mass that I found and my doctor corroborated. It was palpable. In other words, we could feel it. And at the time, it was actually also visible. It was close to the surface. My mammogram at that time was still normal. And so I don't want to scare anybody off of getting mammograms. You must get your mammogram. They really do save lives. In my particular case, my breasts were so dense that it was hard to see things. The things we look for are called calcifications, and they are white. And density is also white. So density can hide things on a mammogram. And so for women with very dense breasts, sometimes, not in every case, but sometimes additional screening in the form of ultrasound might be indicated. That's called supplementary screening. And so my experience was a little bit different, but I still want to strongly emphasize the absolute necessity of screening mammograms.
Absolutely. Yeah. And you were saying yesterday, even though we have a lot of information around how important it is to get these mammograms, many women still are late to getting them and aren't prioritizing them. A lot of us are, but yeah, this is our shout out. This is our plug. Make sure you're getting your these exams when you need to be. And I love that around the dense breast tissue. It's so important. So do your own self exams as well. I'm not the doctor, but plug.
Yeah, what I tell women, I think women are often not getting mammograms because they're confused by the different recommendations. Different societies tell you to start at different times, and how often to do them is different between recommendations. And I think an important point is that every society takes different factors into account when they're making those recommendations. I tend to stick with the most conservative recommendations, which is starting your mammograms at the age of 40 and getting them annually, especially with someone who has dense breasts like Lisa did. That year after year after year, looking for subtle change is what actually picks things up when the actual image is a little bit less quality because of the density. So it's really important. The other reason I make that recommendation is that, women get breast cancer throughout their lives, right? That it doesn't, we actually see more breast cancers as women get older, but they tend to be the less aggressive ones. The ones we pick up earlier can be more aggressive. So I certainly want us detecting those as early as possible.
It's so important. Yesterday, we were talking more on that, that survivorship mentality that we bring to the table at Gennev, but in oncology, sometimes that's a little bit lacking. Do you want to talk a little bit more about what that looks like and that intersection between breast cancer and menopause?
I think Dr. Savage and I both have the same approach to this. In fact, all of our physicians at Gennev do, which is that breast cancer is important to detect and treat, but women are going to survive their breast cancers. 95 to 99% of women will survive their breast cancer, and they live a long life. So what we need to focus on after the cancer is how do you live the best quality of life for the rest of your life? And it's not to put down oncologists. They have a job, and their job is to cure the cancer and keep you alive. It's our job here at Gennev to say, okay, they did their job. Let us now help you to live that life as best you can.
Yeah. Quality of life always.
Mm-hmm.
Yes.
It's huge. And, I love my colleagues in medical oncology. we can help them help their patients. We really love to collaborate, and we're not here to take the place of anybody else's in-person physician, but we really can help, not educate only patients, but also colleagues in the medical field, and we try to do that.
Excellent, excellent. Yeah, and going into menopause treatment and that intersection between and how we can help women going through breast cancer or have had breast cancer relieve their menopause symptoms. Can we talk about those alternatives and what we can and how we treat them at Gennev? Dr. Dunsmoor-Su, can you talk about hot flashes?
I can always talk about hot
All
flashes.
day long, all day long.
Half the time while we're having a webinar, I will have a hot flash.
I'm having one right now, actually.
Hot flashes are the symptoms that most people recognize as a sign of menopause. Many women have them. Up to 80% of women will experience hot flashes, whether that be the nighttime ones, which we sometimes call night sweats, because you wake up in a full sweat, you've missed the hot flash and gone to the other side, or daytime hot flashes. And they are, your brain is signaling your ovaries to work. Your ovaries aren't responding. So it also signals your warm sensing area in the brain, and that alters how you perceive the normal temperature range and makes it very small. That's why whenever you excurse out of it, you have this huge flash. Traditionally, best treatment for that is estrogen. But of course, for our breast cancer patients, that is not an option. So we have lots of other things that we can do. I always start this conversation with the non-medical interventions that you can take. We talk a lot about layering and fans and light, natural fibers and all these things. And all of those are helpful, but sometimes that's just not enough. And then we need to treat you. There are no proven herbal remedies for hot flashes. There are a lot of herbal remedies sold for hot flashes. None of them, when studied head to head to a sugar pill, do any better than a sugar pill. But here's the caveat to that. Sugar pills do pretty good 25% of the time. So you know what? If you're taking an herbal that is safely made and not dangerous and it's helping you, great. No problem with that. I'm just saying that as a physician, I don't prescribe them because I don't think they have significant benefit. Acupuncture has a little bit of evidence for benefit. There's one small study that looked at acupuncture versus sham acupuncture and said, hey, the real acupuncture is a little bit better. But again, small studies, but again, also no harm. And acupuncture can be a great form of meditation. So I'm all for it. In terms of medications, we have sort of a couple classes of medications that we've tried. For years and years, we've used some of the antidepressant medications, and they can be very beneficial. They can reduce hot flashes by 40 to 60%, depending on the woman. They can have an added benefit of mood elevation for some women if they're also having sort of a cross symptom there. They're pretty easy to take. They're once daily pills. We have another medication that I tend to use, especially in women having a lot of nighttime symptoms, called gabapentin. This is a medication that was developed for neurologic issues, but it seems to reduce hot flashes pretty significantly and has a nice added side effect of making you a little bit sleepy.
That's a very nice side effect.
We actually, excitingly, have a new class of medications just to market this year. The example we have on the market that was just approved by the FDA is fezolinetant, or Veozah. They're running all those VMS commercials like in the Super Bowl. And it works directly in the center of the brain that is being overly signaled to block that signaling and reduce hot flashes that way. And their evidence is very good, about 60 to 70% reduction in hot flashes overall with taking that medication with pretty limited side effect and risk. So lots of great options on the market now for women whose hot flashes can't be controlled with lifestyle changes alone.
That's incredible. Listener, if you have any questions to ask, please put them in comments as you're watching our broadcast. The doctors are here, and we will take comments and questions throughout and at the end. That's so important. Hot flashes are so hard to manage. And I know that the hormone replacement therapy helps so many women. And when you can't use that, going into these other strategies is incredibly important to know that they exist and to know that there's lots that can be done.
Absolutely.
Dr. Savage, moving on to vaginal health and vaginal sex and healthy sex during menopause, intersecting with breast cancer. What do you have to share about that?
Oh, I have a lot to share. I have really strong feelings about it. It's one thing to be diagnosed with breast cancer, undergo treatment. It's not easy, and the treatments can result in lack of sexual function. They can result in vaginal dryness, pain with intercourse, irritation, more predisposition to infection, etc. It's because the tissue quality and integrity can be compromised. Menopause in and of itself does that. And then you add on breast cancer treatments, which can include anti-estrogen medications, and you really, really can have a problem. So my shout it from the mountaintops message is that vaginal estrogen can be used by almost everyone. It can be used in breast cancer patients. It is not absorbed systemically to any measurable degree. It is local therapy. And this is what we have to educate our medical oncology colleagues about, because sometimes the word estrogen sends everybody screaming and running for cover. With vaginal estrogen, that is not necessary. It's a game changer. It can be used safely, effectively, and indefinitely in almost everybody. And so I really want to encourage women to put their heads together with their clinicians. Come see us if you need to. We are not the least bit hesitant to prescribe vaginal estrogen. We know about its benefits. And another side story, when I first walked into my medical oncologist office as a newly diagnosed breast cancer patient, we said our greetings. He was an old colleague and friend. But then I launched into my little speech about the fact that I was using vaginal estrogen, intended to continue using it, did not want to hear another word about it. Thank you very much. And he looked a little taken aback. But he said, well, okay, you probably know more than I do about that. And I said, yes, sir, I do. Thank you very much. End of discussion. And so that, I feel really strongly about it. So many women are scared to use it. They're scared of the E word, estrogen. Their doctors are afraid of it. And that's where we can really educate not only patients, but other clinicians about the safety and effectiveness of vaginal estrogen, which can be delivered via a variety of mechanisms. We have a cream, a pill, an insert, a ring. I also want to mention, and perhaps this should have come first, but I'm such a what do I want to say? I'm an ambassador for vaginal estrogen. But there are over-the-counter products that can be quite good. Moisturizers. There are many. A lot of them are available at your drugstore. Some are available through different companies via mail order. And so there are some really good moisture products. They treat a symptom, and those can be used with vaginal estrogen. You can do this on some nights and that on some nights. But moisturizers in and of themselves, they don't treat the root of the problem. And so that's why I'm a really strong advocate for the use of vaginal estrogen in women who have symptoms of GSM, genitourinary syndrome of menopause. It can be so limiting, but it can be remedied. And so that's what I want to make clear to everybody.
Can I add two things to Lisa's discussion, which is, as always, fabulous? One of those is when we talk about using vaginal estrogen, we talk about using FDA-regulated products. There is absolutely no role for any compounded vaginal products in women with breast cancer because the dosing is unreliable. So no one can tell you you're not absorbing that. So only the things you can get from your pharmacy. And second point is that there's a great opinion piece from the American College of Obstetrics and Gynecology that looks at vaginal estrogen and systemic absorption in women with breast cancer. And they agree that for women with breast cancer, this is a very safe option to use. They do make one qualification, which is women in aromatase inhibitors might want to try moisturizers first, but if that doesn't work, then they should move to vaginal estrogen. So there's a lot of thought behind this. But it needs to be done with someone who's expert in it and who's going to use the right dose and the right product.
Yes.
Oh, yeah. Oh, excellent. You both are so smart about this. And I always learn so much just being with you.
Well, we are both big vaginal estrogen advocates and users.
Yes. Yeah. It adds credibility to our recommendations when we have personal experience with it.
Yeah, when patients say, would you do it? I say, I do.
I do it.
Of course I do.
I can show you my box. I
Started
can
a
give you
meeting.
the demonstration. I think that really helps. I mean, you don't want all of your doctors to have suffered whatever it is you are diagnosed with. But it really does add, I think, some credibility to our recommendations. It adds a personal touch. We can really develop a rapport around this issue because we've lived it. And so I like to bring that to patient appointments when it's appropriate.
Yeah, absolutely. Absolutely incredible. Well, let's move on to sleep. In the Facebook community, we've got over 8,000 people with ovaries and community members in there, and sleep becomes such a problem during menopause, during various stages of menopause. I struggle with it myself in peri. Dr. Savage, what can we do about sleep if we've had breast cancer or dealing with that and have some limitations?
Well, I want to talk about sleep. A lot of what I'm going to say applies to everybody across the board, but especially for women who cannot take estrogen or don't choose to. Sleep is critical. And I always say it's sort of the common denominator or the cornerstone behind a lot of downstream symptoms. And those include body aches, joint pain, mood, cognition. Sleep is critical. And if we can improve the quality of sleep, then a lot of those other symptoms are also going to be benefited. So what can we do about sleep? Well, the first thing is what we call sleep hygiene, and most women know what that means. You want to standardize your bedtime and wake up time, even on weekends. You want to have a cool, dark room. You want to minimize interruptions, such as from pets. This sleep hygiene is sort of the first step. And the first thing I ask patients is about their sleep hygiene. Now, the one thing that I have a hard time convincing everybody of is that sleep hygiene includes the absolute necessity of getting off your screens before bedtime. TV, especially your phone. Everybody's got their phone right up until the minute they want to turn out the light. Don't do it.
Don't do it.
You really have to take that to heart. Screens emit a somewhat of a blue light, and it interferes with melatonin, a hormone from your brain that helps to maintain sleep. So sleep hygiene is number one. Number two is CBT, cognitive behavioral therapy, -I for insomnia. CBTI has to do with identifying and changing behaviors around sleep, those that go beyond the sleep hygiene. There are doctors who specialize in sleep medicine, and there are therapists who specialize in sleep therapy. So I refer a lot to these colleagues of mine because sleep is so critical. CBTI has been shown to be as effective or more effective than medications. There's more effort involved. You have to explore it. You have to learn about it. You have to enact the recommendations. But long term, I strongly prefer it over medications. Speaking of which, there are some that can play a role in sleep for women who cannot take estrogen. Rebecca mentioned gabapentin. That's one of the main things in our toolbox, because taken at bedtime, it can reduce those nighttime warm waves or hot flashes, night sweats, and it has sedating effects. So gabapentin can be effective. Also, the class of antidepressants known as SSRIs or SNRIs can also be helpful in that regard. I usually talk to patients about what other symptoms they have, and I sort of curate what I think would be best for them based on their overall picture. I do want to make a note that one of the common medications called Paxil or paroxetine, also known as Brisdel, shouldn't be taken for patients on tamoxifen. And a lot of cancer patients are on tamoxifen. So you can cross that one off, but there are others in the class. And so we can take into consideration the whole big picture and try something. The other thing I always like to say is that some of it is trial and error. You try one, doesn't work so well. You try another one, now you've hit it. So so sometimes patience is required on those medication options, but you can see that we have a whole toolbox full of things between hygiene and CBT and medications to help sleep. And to me, it's probably the most critical aspect of overall well-being.
I was going to say, Lisa, you didn't mention the traditional sleep medicines. You want to
Oh,
go
the
into
Z
that?
drugs.
Yeah.
There's a reason for that, because we don't really promote them. They can have a place short term. Your Ambien, Lunesta, all those drugs. I see so many women on trazodone, which is sort of a Z drug. It's got a Z right in the middle of it. Z for Z's, I guess. But trazodone, as much as it's used, is off-label as a sleep aid. It is not approved for that. It is an antidepressant. But a lot of women are on trazodone, and it's hard to try to convince someone to try something else when that seems to work. But those drugs can have long-term effects. They can be habit forming, either physically or mentally or both. Also, over-the-counter meds, we want to mention those, your Benadryl, et cetera. And those can also have adverse effects and be habit forming. And they can even have long-term adverse effects, such as cognitive decline. And so you want to be careful with those. I try to talk most people out of them, to be used with caution and only short-term if possible.
Yeah, they just really cover up a symptom. They're not solving the fundamental problem.
They don't result in the most restorative sleep either. There's a difference. We talk about sleep architecture, the REM sleep and the deep sleep, and those meds may help you fall asleep, but then your sleep architecture is not actually as restorative as it is with falling asleep without a drug like that.
Yeah, and I think that consistency on the other side of us, creating that sleep hygiene as you're talking about, and us then saying, okay, I'm going to do this. I'm not going to actually sit on my phone and on my screen in the dark, which I've done, and I'm working on this. And it does help to have this boundary in place where I put it away and I read a book and slowly drift to sleep. And so, but it is a problem for me, and I'm working on these things.
We should have a 12-step group. There's a little bitty book called How to Break Up with Your Phone. It's a really good book. I recommend
writing that in the notes. How to Break Up with Your Phone. That's a great one. Yeah, we should find that one and probably all read it.
Yes.
Yes.
Well, last symptom, mood and mental health. Dr. Dunsmoor-Su, can you tackle that?
I can. This is a complicated one. So I think there are multiple things going on here. We know that with menopause, there's, especially in perimenopause, an increase in sort of anxiety type symptoms and depression. And then in menopause, we can see a bump in depression, especially early on. So that's independent of everything you've just gone through with breast cancer, right? So you may have gone into a sudden menopause. You may have had disfiguring surgery. You may feel like your relationship is suffering. Like there's so many other things going on that mood symptoms are pretty common during this time. What I like to do, much like Lisa said for sleep, is I like to explore, well, what are all of your symptoms? Are you someone who's also having pretty significant hot flashes and trouble sleeping? I might recommend one of the SSRI or SNRIs that's a little bit sedating that you can take at night, that doesn't cross-react with your tamoxifen if you're on it, but that also might help with your hot flashes and might elevate your mood. It is worth treating your mood. I think we often discount mental health symptoms as something we need to power through, or if we were just stronger, we could overcome this. They are a medical condition due to a difference in brain chemistry, and we can treat that. And even mood changes that might be what we call situational. You're a little bit depressed because you just went through breast cancer, or you're getting treatment, or all these things are happening. It's okay to treat those. It will make you feel better, and it will make you heal faster. I think a lot of women are afraid if they start an antidepressant, they'll never come off of it. And that's not true. Many women need them for a very short time-limited period, either for symptoms or for mental health. And then they come off of them perfectly well. So let us help you to live through this as best you can. And let's treat those symptoms. And if you do need to be on them long-term, that's okay too.
Yeah. And let's just say, plug, it really matters who you're working with. Come see us at Gennev if you are looking to work with a menopause expert, doctors and health coaches who know about menopause and these various intersections that we're talking about.
I
Let's
wanted
go a
to
little-
hug also, Melanie, the fact
Yes.
that one of the symptoms we're not going to get to because we've just had so much to say and we're running out of time is weight changes and body shape changes. These are very common for all women going through menopause and especially with breast cancer treatment. And our RDN team, our registered dietitian nutritionists who are expert in menopause physiology, we even have a certified oncology nutritionist on our staff. They are phenomenal for helping women to think through long-term lifestyle changes for long-term health that may result in a shift or a change in weight. But really our focus when we work with women is how are we going to keep you alive to 90 with a healthy heart and healthy bones and feeling good about yourself.
Yeah.
A healthy brain and feeling good about yourself.
Yeah. Oh, isn't that amen? That's so true. We do have one question.
Yes.
I know we're a little off time, but let's just get
That's
through
okay.
it. It's a great one. Do you recommend that menopausal women be gene tested for BRCA1, BRCA2 if they are unsure of their family history of breast cancer?
That is more of a question than we can answer via webinar. My recommendation for anyone who wants to explore BRCA testing is to actually speak with a genetic counselor.
Absolutely.
I think they are a wonderful resource. Insurance almost always covers that consult. And they can talk you through the pluses and minuses of that testing, what the implications are, what you might choose to do if it comes back positive, and what those implications are for your family or for your mental health, because it's a bigger thing than just knowing a fact. I think sometimes and also it's really important because BRCA we think of as breast cancer gene. But actually, it's the breast, ovarian, some uterine, some colon cancer. There's a lot, pancreatic cancer. There's a lot of cancers that come into the BRCA gene. And I want someone who's expert in counseling you about that gene to talk to you about it.
Such important advice. So good. Yeah. Well, that's it, you guys. Thank you all so much for joining us today. Thank you to Dr. Savage and Dr. Dunsmoor-Su. You're both amazing and a wealth of knowledge. I so appreciate you spending your time with us this morning. Next up on October,
Melanie.
What was that?
I said, thank you for hosting us.
You are welcome. I'm going to do I want everyone to know that next week on October 11th, we will be going live on Facebook and LinkedIn again with Katie Linville to talk about nutrition and lifestyle support for breast cancer and menopause. Dr. Dunsmoor-Su kind of mentioned this, but Katie is one of our amazing registered dietitians. She's a menopause expert and also a certified specialist in oncology nutrition. She's great, and we can't wait to bring her amazing wisdom on next week. And one last thing, I'm here to remind you, you don't have to suffer through menopause alone. There's a fantastic Facebook community called Menopause Solutions by Gennev with over 8,000 members discussing their experiences, comparing stories, and we're there moderating. The docs are in there. We're trying to bring accurate information to the forefront. And there's also real medical treatments and lifestyle treatments out there. Great expertise to tap into. So go to www.gennev.com, book your appointment. We have doctors in all 50 states, and you can get connected usually within 3 to 5 days, which is an amazing turnaround. You can get help and relief quickly. Ladies, it's worth investing in yourself and in your quality of life. All right. Thank you all. We'll see you next time.
Take care. Thank you all.
Bye.